welcome to our educational event for October. So today what we have for you is I will do a brief introduction, and then I would hand over to Ourania, who we are delighted to have with us today. Then we'll talk briefly about our upcoming events, and we would ask you for feedback. That's the way we can say thank you to our facilitators for taking out time to be with us today. So just a brief intro about who we are and what we do. So we are a regional research network within Yorkshire and Humber area, and we are part of the LCPCH Training Research Network. And basically what we hope to do is to bridge the gap in trainees' access to research opportunities. So what you would expect from us is to advertise research opportunities, not just within the region, but also LCPCH, and signpost you to available opportunities. We would every month provide you with some educational opportunities. So at the moment, we do a teaching section, and then we rotate this with journal club every other month. And then we are a platform where you can bounce off ideas if you're hoping to do a multi-center regional audit, QIP, or research work. So today, what we have in stock over the next 1 hour is a talk from Dr. Ourania. So just a brief introduction about Dr. Papa is that she's one of the QIP fellows at Leeds Neonatal Intensive Care Unit, and she's a post-CCT neonatal spin. Rania has done a lot of projects which has won awards at both SOPAM and also at the national conference. And some of these QIPs have also been published in BMJ. So you find out that these are high quality QIP projects. And we are hoping that at the end of today, you might be able to see some projects which has been carried out in Leeds and consider how you can collaborate with us and carry this out at your own center. We are hoping it can be sort of a multi-center regional audit. So I'll hand over to Ourania, who would be talking to you about the next 45 to 50 minutes. And then I'll come back to tell you about the feedback and other things we have in stock for you. Thank you so very much. Rania, over to you.
Oh, thank you so much, Diane. Honestly, thank you for your kind words as well. Hello to everybody. Yes, I'm Rania. I'm city spin unit trainee towards the end of my training. I apologize to Verena and Diane and everybody involved. I have been trying to organize this session since July, I have to be honest, but then we got there in October. So at least better, we got there. That's the most important thing. And I think Diane has actually covered everything. This is what we are going to talk about today. We are going to talk about the projects that I have been involved in Leeds, because the neonatal units of Leeds are with a great reputation about quality work. But what I'm going to talk about today is that for the ones that I have been involved, I feel that they do have the potential for wider implementation, not only in neonates, but in pediatrics as well. So let me share my screen. I think I will do something very brave today, because I'm a big fan of Mentimeter, but then for a reason, Mentimeter wasn't working with my slides in PowerPoint today. So I will ask for some brainstorming from you guys, so we can make it a little bit active as well. But yeah, reason my Mentimeter was not working. Here we are. Yes, we covered the introduction. So the aims of the presentation today. First of all, the first question is, why are we talking about QI in a research meeting? Is it because I love QI and I knew the people, I know the organizers of BRIDGE, so let's throw QI into the game, because those two big topics are closely linked together. And why is it important to deliver QI in every single department? How do we make it work locally? And when I mention locally, it's neonatal and which projects could apply in other specialities, which is the vast majority of slides. And do I have to suggest any QI resources or training material? So let's go to my presentation Mentimeter. So if you could please scan the QR code. So I figured out, can you actually, here we are, we minimize.
But we can't see your slides, Rania.
Can
It's
you
just
see
on
that
share
slides?
screen.
Okay, wait. Can you see them now?
Yes, we can. Thank you.
So if you please could scan the QR code and tell me about the first thoughts that pop into mind when everybody's talking AI. What are your first thoughts? And what, yeah, what, yeah, what are your first thoughts? What the first thing that pops into mind when asking? I think I have given you the option to give the answers, but anything, even if it is absolutely fine. Saints. So the answers are mainly around work, yes, team working again. So mainly the answers are around team working, work, tasking. It's about the work that we are providing towards the department, and that work has the main target of delivering good quality care to our patients and some sort of change because probably it's not working right. So if I go back to my presentation again, share. So you did mention, somebody mentioned that it's poorly defined, but I have actually, and thank you for whoever did that, because I actually have a few definitions of quality improvement. My favorite one is this one, which is, so it is the definition, yeah, it's improvement in patient outcomes, system performance, and professional development. So we're not only doing QI work to deliver the best possible care to our patients, but it's also to create an ethos and a culture of improvement, which will also help us for our own professional development. Because the more you work on QI, the more you realize that you can spot what doesn't work right. And that comes from personal experience that I have been doing it for the last couple of years. When somebody comes and says, you know what, I think I can deliver that sense. It now the older that I grow, the wiser I grow through quality improvement, and I can tell whether something will work or not. Or the change needs to be tested. But then that's how it works towards your own professional development again, and it's all about teamwork. And well done to everybody who has wrote about that, because quality improvement, it's not a one man, one woman show. It's a multidisciplinary approach on how on a delivered change. And this is a delivery, and another definition is about the delivery of healthcare with improved outcomes and lower cost through continuous redesigning of processes and systems, and also, sorry, using a systematic change method and strategies to improve patient experience and outcome. So that's a few definitions that I will give you the references by the end of the presentation. But is it enough? No, it's not a silver bullet that for all change in healthcare, but it does have a great potential. And it's to me, it felt that it was the easier way to start on your research journey, professional development journey, but as I said, it's not a silver bullet. So quality improvement works concurrently, for example, with audit to test changes and consecutively. So we use QI to adapt published research to local context, or we use QI to find a way of delivering our changes out there and producing through QI our own research work, if it makes sense. And then as QI becomes established, opportunities for these collaborations will grow for the benefit of patients. So the more you do it, the more established it gets, the more benefit you offer to the patients. I can minimize this window. So this is one of my, if you only have to read a paper about quality improvement, is the one that was published in 2020 in BMJ, and it's called Quality Improvement in Practice. It talks about the diagram of the four sciences incorporated into quality improvement. So if you see this spooky spider web, just to be yeah, I mean, just to put it into these days context, you will see that quality improvement is in the center, and then you have four different boxes at the edges. I have missed the titles for the red one and the orange one, but the red one is audit, the orange one is research, and then we have service and clinical transformation. And you can see how everything fits to each domain. So first of all, you can't provide quality improvement if you don't use your audit, because audit is the way that you are going to measure your change through continuous auditing process. But then even it can work the other way as well. So you might find yourself that you have a clinical audit that has been ongoing for a while and has spotted a non-compliance with the best practice. So you can then put quality improvement in place to solve this problem. Then quality improvement can raise questions about best practice and can help and can feed into research. And then quality improvement allows the small scale testing of plotting ideas before they are implemented in full. So all these small tests that we are doing with quality improvement can actually feed into clinical transformation. And then there is a project that we are running in Leeds that has set the foundation for a service evaluation as well, and I will talk about that later. So something that we have done and shows that we need meant different changes on our services, generally speaking. So that's one of the papers that I definitely recommend, especially to those that are skeptical about quality improvement. And then let's go to the next slide. And why is it important to deliver QI work? Because you want to provide the best care you can to your patients, which is effective and safe. And this care should be well-led, sustainable and equitable, and achieved through providers and commissioners working together in partnership with and for local people and communities. So safe, effective care, which is well-led, sustainable and equitable. That's why it's important to deliver QI work. Before I actually mention what is happening locally, I will stop share again, which is again something very brave to do, and then ask you the following. Let me just go back to the presentation. Share and go to screen and go to Mentimeter. So, and here we are. So the next question is, what do you find inspiring about quality improvement? I think this is coming from the previous question. But yeah, scan the QR code again. We will put that into the next question's context. And tell me about what you find inspiring yourselves about QI. If you have been involved, is there something that you're finding inspiring? Drives change, yeah, great. But mentioning, I mean, commenting on the difficult and laborious comments from the previous question, yes, it is difficult. It is difficult if you don't know how to do it right. I think what we are missing, I'm not sure whether it's regionally or nationally, is awareness of the QI methodology, which I will mention later on. So it's not that difficult. It's the fact that we are missing we haven't defined ourselves quality improvement as well, and we are missing knowledge on QI methodology. So drives change, working with new people gets people thinking. Excellent. And it again, as you notice, everybody mentions about teamwork. Again, that I couldn't highlight that enough. Quality improvement is about teamwork, not a one-man show. Getting a lot of ideas into place and working and putting everything into order to see how much it can be done and to deliver change. And what do you rewarding if well focused? I don't, yeah, good. So that's actually very it can be very rewarding, especially when it's well done and it gives you it gives you back. And we'll talk about that moving forward. And what might be discouraging, you think, we will think? And before you actually submit something, I would say that discouraging might be if you feel that you're not part of the team again, or the fact that you are drowned in a lot of data and you can't find what's the purpose of what you're doing. Oh yes, I mean, uneven participation, it's a little bit discouraging. Equipment availability, I believe it's more about resources and the lack the time of it. That's what everybody mentions. And if difficult to implement change, yes. There are some departments that are more prone, not no more prone, more open to change than other departments, and I do appreciate that. Not having buying from, yeah, good. So everything is mainly about the time that we don't actually have a lot of times to deliver QI work, the time that we don't have to actually do what we would like to do. But locally, we are passionate because, again, it's about the care that we are providing to our babies, and helps us to make substantial lasting changes in safety, quality, and experience by reducing waste and maximizing the value of what we do. And then over time, and the more we're working on it, the improvement work has become part of business, and it has become part of the everyday activities. So yes, there are difficulties. Yes, there is not allocated time. I think a lot of things that I had achieved was part of my QI fellowship and the fact that they had allocated time, but we are getting better on giving SPA times to the trainees. So this time can actually be invested in quality improvement, and I think the outcome will be very fulfilling with regards to what we get for ourselves and our portfolio at the end of the day, but mainly what we are going to achieve for the care that we are providing to our patients and to the services. So again, locally, how do we make it work? It's all about teamwork. I'm so happy that everybody mentioned teamwork on the factors that will support you towards QI, and that's what we are doing in Leeds. We do have a dedicated QI team with a lead consultant, a lead senior nurse, and a lead ANP, and we are trying to establish something which is called QI buddies. So what it is, it's a nice way of actually getting more people involved. So what we will try to do is to get a couple of 2 or 3 trainees that they will work with a senior person to just deliver training in QI, or just share information about all the projects that will be running in the unit. This is something that has come as an idea recently, and we are working on it locally. But what has been well established and has been done is that every 6 months we do have several QI projects that we distribute to the trainees. We allocate the teams with one lead consultant or one co-lead HST, or senior NNP with 3 or more LSTs. And recently we had a lot of powerful nursing support. And then we have a couple of QI meetings in Leeds to share information and share our action plans. And then we do have a lot of numerous resources available. Now we are focusing on teaching sessions, and we are also getting feedback and we are asking for feedback, and we are providing support with the PDSA cycles. And what we have done recently is we have created QR codes that are widely distributed to the team. It has only been like the last 6 months that we are doing now that. It's about QI methodology, how to start, because I think that's what a lot of people are finding challenging as well, and what the PDSA cycle means, how to collect your data, the importance of baseline data, and more QI methodology like a fishbone diagram, a driver diagram, resources about where resources and where you can find information about these forms of QA methodology and the importance of the run chart and how to actually create it. So we are trying to organize a QI board in the seminar room of the neonatal unit and share all this information there, and that's what we have recently done as well. So going into the, after a lot of introduction, what are the projects that could apply to other specialities, and how they can actually deliver change in other departments as well. So one of the big that have been involved is around neonatal central venous catheter safety. We've recently published our work, and that's the title actually of the publication. This is the first one that I'm going to talk through, and then we have done a lot of work in reducing radiation exposure as well, with a project which is called Am I X-ray Ready? And then we have been using a lot procalcitonin for antimicrobial stewardship, which is, I feel that it gets better and better established. So the CVC project, and yes, we're talking about neonates, but central venous catheters are being used in pediatrics as well, and are being used in oncology, in PICU, so it can be applicable to other departments too. So in that project going back to when it started in December 2021 when we had 2 cardiac tamponates, one of misplaced long line and another one from a migrated long line, which led obviously to research scenarios and collapse of 2 babies, which obviously, not obviously, which both of them were successfully resuscitated. But then it made us think, what is happening now, and why did we have 2 cardiac tamponates within 6 weeks? The project for CVC waste reduction mainly existed at the time, so we were kind of reviewing our packs and what we can make, how can we simplify the packs that we had at the time, the long line packs and the umbilical catheter packs. So that project existed, but from a completely different mindset. So what we did is we took this project and we assessed our practice, ways of monitoring those lines, and why and ways of and techniques of securing the catheters. So that's the importance of baseline data that I have mentioned. We reviewed 12 week of baseline data before actually those incidents happened, or it was those few weeks were actually part of the baseline data. And we noticed that almost 28% of all our central venous catheters, UVCs and long lines, were in an unacceptable position. So we kind of color-coded all our catheters and we categorized them on green, amber and red. And we did find out that 27% of our catheters were red category. And this is where QI methodology comes, because that sounds like a massive problem, but how do you tackle such a massive problem? The wishbone diagram is a cause-effect diagram, so what it means is that you break down your problem, as simple as that. Because and how it works is that on the head of your fish, you do have the domain that you want to change. And that in this instance, it was the red lines. We want to reduce the number of red lines. 27% was completely unacceptable. But what was going wrong? So the categories that we focused on was staff and knowledge. So there must be something that is wrong, completely wrong. It's the fact that probably our staff don't know what a red line means. So we focus on staff and knowledge. We focus on environment. What do we do as a unit to support knowledge? on our materials. Is it something that we are doing wrong with our technique, maybe? Do we have the appropriate steri strips? Do we have the appropriate tegaderms, for example, or any other securing device that could help us? And the procedures. So what are we doing to make sure that the line tip is assessed consistently? So a lot of PDSA cycles, I do have, I'm so sorry that that these PDSA cycles are very small, but I do have a QR code later on for the paper, so you can actually read the whole paper. What I have circled on those cycles is that they are a lot, as you can tell from this summary. They seem to be five, but there are like five with each one of them have another three domains. But what I have circled is the fact that everything that we were doing, we were testing it and we were deciding as a team whether we need to adopt the change or abandon the change. And the first change, it was to raise awareness. That change itself, raise awareness of the events, deliver and mentioning to the multidisciplinary team, nursing, medical team, and the fact that we became aware of these incidents made us more cautious when interpreting line T position. That dropped our red lines from 27% to even 12%. So it halved the number of red lines that we had. But what we really want to make sure at the time was that that change was sustained. There were a few other changes that work, like we're trying to collaboratively work with the radiologists and get timely reports, but that wasn't happening, so we abandoned these changes. But what the main changes were that made a real difference is three posters that we created as part of the project. A traffic light guide that hasn't been incorporated into our guidelines, which actually shows where a line tip should be. Green is for go and use for PN. Red is for completely unacceptable. Pull the line back, remove the line. You're not using it even for clear fluids. And then amber is a line that can be used for a short period of time, and then with the first chance, replace it or only use it for clear fluids. And then as part of that project, we realized that a lot of the quality of the x-rays were so bad that we couldn't interpret the line T position, or even we thought we could interpret it right, but it was a completely misaligned image that was confusing us more than actually helping us find the line T position. And then we developed that poster for reassessment of the peak line and how we can actually step by step secure the catheter correctly. That's for long lines. We also created a survival guide, which incorporated regional, local guidelines, national guidelines, and some tips some information that was coming from the QI project. And that's the line chart of what happened by the end of it. So this is the first bit before the PDSA cycles is our baseline data, and you can see where our catastrophic events came. It was, I think it was, that event was one of them, and then a little bit earlier was the other one. But as you can see, if you calculate the baseline data, you can identify how many red lines approximately you have per week. So now we are way better. But at the beginning of the project, we had approximately 2 lines which were in not an acceptable position per week. But then we kept being above the median baseline for a while, for pretty much every week before the implementation of the project. And since working our PDSA cycles and ongoing monitoring of the line tip and change in culture of assessing the line tip position in central venous catheters, we have been consistently below the median baseline, and I keep monitoring our progress. And we have become so much better in identifying problems, recognizing complications, and since we implemented the projects, we had minor complications and nothing that's catastrophic as a cardiac tamponade. And this is the paper that was published in August, and this is the QR code if you would like to read the paper. It was published as a short report on education practice. And then another thing but I won't mention a lot of details. So that's another bit of the project that was presented last year in BAPAM, that we realized that limb position also affects the line tip position, and that's where a lot of confusion were coming when we were assessing our line tip. And we did a literature search which showed that, and we found 7 papers that were saying that arm position really affects your line tip position, and that we incorporated that on our subsequent X-ray project, which I will talk about later on. And the other bit that we did is we incorporated into our practice line glue, which is a central venous catheter specific glue which reduces the risk of movement and dislodgement of the vascular access. We were the first unit in the region to implement that. And we have recently audited our 6-month worth of data since we started using the line glue. Unfortunately, we do have poor compliance, so only 28% of our catheters have been glued. But if you see, UVCs are a little bit tricky. Because they do naturally move, but but that's outside the topic of this presentation. But with glue and standardization of limb position that I'm going to talk about later on, we have eliminated migration. So that's one of the projects. The second project is about X-rays. The reason that we worked on it was because we identified so many problems with the quality of our X-rays when we were doing the line project. And the other thing is that we noticed that we were repeating so many X-rays, especially for line position, but then for other reasons like abdominal X-rays for suspected necrotizing enterocolitis, and a lot of X-rays for ET position as well. So we were kind of trying to find a way of reducing the repeated images, and mainly focusing on improvement mainly focusing on the improvement of the quality of the images. So we know that the most preterm images have an increased overall exposure, and there are studies to say that, on babies less than 750 grams that are surviving the NICU journey, there is a median number of total X-rays of 31. And there is a global consensus that the dose that we should be delivering to these babies is as low as reasonably achievable, but we don't know what's exactly that dose. And there are more up-to-date imaging protocols about dose limits specifically for the NICU environment. But again, I don't believe we are following these protocols, and there is no consistency there is no consistency in practice from one unit to another. So the aims of that project was, as we said, the quality improvement of images, the reduction of repeated images in the 3 most requested categories of X-rays, a sustained change, and then could we find any other alternative methods that could support the reduction of radiation exposure? So long story short, we wanted to stop those images because if you can see, especially on the second one, the whole baby is included on the X-ray, and there is also a hand on top of it. So we want to stop those and have well collimated images that actually can provide some information, no artifact, well aligned, and of great quality. So we had 4 PDSA cycles on this project. We identified our baseline data, and we isolated the 3 categories that we had the most requests, and that's for a line tip position, ET tube related, and abdominal X-rays. We did introduce, so that was a multidisciplinary project. So we asked for the radiographers and the radiologists to come along and help us because there was no way to reduce radiation exposure in the department without getting them involved. So we did present a lot of data in our department and in the radiology department. One of the senior NNPs created the poster about which we call "Am I X-ray ready?" about what it should be done from a nursing perspective and a medical perspective before we actually take that image. And I will show it to you later on, which was very, very useful. We have delivered bedside teaching with nursing and medical staff, and then and we on the third part of the project we really focused on delivering our thoughts and action plans to the radiology department. We did design a neonatal radiology guide, and we incorporated our guide and the poster on the in the trust's radiology guidelines. And then, as a last cycle, we cooperated with Trust senior accountants, and we did a cost analysis on how much we managed to save by delivering this project. So yes, a CVC group, an ET position group. On the CVC group, we want the correct alignment of baby's body for umbilical catheters and correct position of the leaves for long line as per local practice. And then on the ET position group, we want to focus on the head neutral position and to remain on midline, because this is a way of avoiding misinterpretation of the tip of the ET tube. And then on abdominal X-rays, we want correct alignment and then correct collimation, because what we had noticed, which collimation means focus in radiology terms, because what we have noticed that we were actually, when we were asking for an abdominal X-ray, most of the times we had all the limbs included, genitalia, part of the chest, and it was like not well focused. And then we also want to reduce the artifacts of all images. So that's the poster. When we actually published the line project, the feedback that I got from a few units in Manchester that I used to work for was, "Do you know what? Can I use the X-ray poster?" And I was kind of like, "Yeah." It was a great tool, and it really specifically says how preparing a baby. And I know it sounds like common sense, but if you go back and see what is done in your place of work, maybe sometimes it's forgotten, or just because we are working in a hectic environment, it's missed because of the workload. So we wanted all the artifacts removed. We want the head in midline for ET check X-ray, and with the central lines as part of the literature search that we had as part of the CBC project. We decided that all the arms should be next to the baby's bodies, abducted at 30 degrees, and then all for the long line, for the lower limb long lines, we wanted the lower limbs on a natural flexed position. And for umbilical catheters, we just want a straight baby to make sure, because it did make on a rotated baby, the line tip was showing completely differently. And this is the next bit is the radiology guide, which is attached on our portable X-ray machine and as an assistant to our radiographers. And yeah, there was change. These are the charts, but what we have done is, first of all, we reduced the total number of X-rays within a 3-month period of time. So when we started the project from July till September, we almost had like 250 X-rays per month. I think this is how it works out, which was 14.5 X-rays per infant. And only 46% of the images were correctly aligned. 44% of the images for an ET tube position had head in neutral position, and as far as the abdominal X-rays, only 36% of the X-rays were well collimated and aligned. And more than 50% of our images had artifacts. But then after implementing the changes and the PDSA cycles, we did have a total reduction of the mean number of X-rays per infant, and we did manage to increase the number of correctly aligned images, and we managed to drop the number of artifacts. And what did the cost analysis show, which was the final bit to convince people, yes, that this is a project worth working on, is that we managed to have a cost reduction of almost of £6 within 6 months, and an average saving per patient of 14 or almost £15. And that's the line chart. As I said, so calculated median baseline at the time was around 220, 230 X-rays per month. So for a long period of time, we were above that median baseline, but then we managed to gradually come down. And by February 2023, we were almost 100 X-rays less than the initial part of in comparison to the initial bit of the project. So we did manage to reduce repeat images by 34.6% and the cost reduction by 30%. We have presented our findings on local radiology meeting. We have created a new guideline which is pending approval, and the guideline is all about indications of X-rays, all the how to do preparation of the patient before the actual image, and then we have highlighted the importance of POCUS for assessment of the line tip, because despite all our efforts to reduce the number of repeat images for CBCs, it's the only way that we have to assess the line tip position. So nobody would and nobody should think about an extra X-ray when they're not sure about the line tip position. So we never managed to reduce the amount of X-rays that we were doing for line tip confirmation. So POCUS is a hot topic in neonatology. We did highlight the importance. We will get training on board. It will take time, but this project highlighted the importance of point of care ultrasound. And the last project is about procalcitonin. So I will talk about procalcitonin, but I'm not sure if you are aware, but the neonatal units of Leeds have been going on, or they have been on an outbreak status for a while now. A few years back it was Klebsiella. Now we are on a serratia outbreak, which is getting better, thankfully. But as part of our review of gram-negative bloodstream infections and the reasons why are we struggling with outbreaks, one of the recommendations was to review, to focus on how many courses of antibiotics we're giving, because this has shown to increase the gram-negative bloodstream infections in neonates. So as part of that, we reviewed all the second-line antibiotics that we were giving in a 3-month period of time, and then after that, we were kind of thinking of introducing a new biomarker with CRP for the time being, but with the hope that at some point, we don't want to replace CRP at the moment, but we want something that will help us guide our antibiotic treatment and reduce the days of antibiotics that we are giving in the neonatal unit. So that's the bit of the project that I got involved with. So procalcitonin is an acute phase reactant like CRP. It's a precursor of calcitonin, which in healthy individuals, it's on very, very low levels on your bloodstream. So if you ever measure, when you're healthy and well, and you go and measure a procalcitonin, it's going to be less than 0.05 ml. So it's when you are well, it doesn't circulate in your blood. It's a 116 amino acid peptide. It's being synthesized on your thyroid. But then when you are affected by a bacteria, any sort of bacteria, it does the rest of your cells, which it can be your liver, it can be your gut, will start releasing procalcitonin as a response to the bacterial infection. And it is well known to be used in antimicrobial stewardship. It's not something new. If you type procalcitonin on Google, you will see that there are thousands of papers. And what I have found really interesting is this. I don't know. So this review, which shows that at present, in 2024, the people that are affected by antimicrobial resistance are 700,000 patients per year globally. But if we don't think to reduce the antibiotic exposure and the prolonged antibiotic courses, by 2050, this number will go to 10 million. And how can PCT help? It has good diagnostic accuracy with high sensitivity. It increases on your bloodstream way quicker than CRP. And then it's very, very useful in identifying bacterial sepsis and guiding your antibiotic treatment. If you achieve therapeutic responses, it will drop very quickly within 24 hours in comparison to CRP that takes almost 48 hours by dropping by 50%. There is evidence to say that when it drops by 80% by the baseline value, in comparison to the baseline value, you can safely stop the antibiotics. And this is a chart that shows you how quickly it increases on your plasma. You will see that it peaks around 12 hours in comparison to CRP that takes longer, 24 to 48 hours. Yes, it can be spotted quicker and guide your antibiotic therapy. So before we implemented actually the PCT, we did a 3-month audit. We identified some 72 courses of antibiotics, and it's not rocket science. So we did identify that most of our extreme and very preterm infants were having a lot of courses of antibiotics, and most of them, more than half of them, we were starting them secondary to respiratory symptoms. But what we noticed, and nobody is going to challenge anybody if they feel that this baby has deteriorated, it's septic. Yes, we do encourage people that if they have any concerns about a baby being unwell, yes, you should. The first thing that should pop into mind is infection, and this is what you should be treating. But we noticed that on 60% of these cases that were starting antibiotics in a 3-month period of time, 60% had 2 CRPs that were less than 5 and a blood culture that were negative. But 37 of cases had more than 36 hours of treatment. And in a lot of those cases, we couldn't identify a reason why they had more than 36 hours of treatment when they had negative inflammatory markers and a negative blood culture. That's what we wanted to do, is not discourage people start antibiotics, and we would never do that. It's just in those cases that the inflammatory markers are low and the blood cultures are negative, to add something onto the game that will help us to stop antibiotics earlier. And by saying earlier is at 24 hours. So if for late onset sepsis, for example, we were to ask a PCT with the first CRP and this on the time of screaming, and the second CRP 24 later, and the second PCT with the second CRP 24 hours later, what we recommend is stop antibiotics in 24 hours. Don't wait for blood cultures, because you do have a biomarker that helps you do that, and then by this way you reduce antibiotic exposure. So we created an informative poster about our audit phase. Diane was involved on that bit of the project as well. And then what we realized is, first of all, we had problems with PCT results. We're getting, unfortunately, a lot of hemolyzed and insufficient results initially. On those cases, the 2 CRPs were less than 5 and the blood cultures were negative, we also had negative PCTs. But on those 15 cases that they were a true infection, there was a quicker PCT than CRP response. And then especially on those babies that presented with severe neck, the PCT rose way quicker. It was very high. We had 2 neonates in that cohort of babies with overwhelming sepsis and a subsequent death that had the highest PCT in the cohort. So yes, our PCT findings locally were supportive of the literature, and we decided to change our practice and incorporate PCT or our babies that are screened for late onset sepsis. We obviously adjusted our guidelines based on that. So the chart on the right-hand side, the flow chart on the right-hand side, shows how we incorporated PCT on late onset sepsis. So what we did is what I have mentioned is along full blood count and CRP and blood cultures. You said that you request a PCT as well, which you repeat after 24 hours. So when that it's not less than 0.5 nanograms per ml, you can stop antibiotics safely at 24 hours. But what we did at the same time is to introduce PCT on early onset sepsis, which was a little bit more tricky, and that's because there was a trial which was published, a randomized controlled trial which was published in 2017, which reviewed the PCT in early onset sepsis. And what they realized on that trial was that physiologically your PCT is elevated when you are a newborn. So you physiologically have higher numbers of PCT if you are to be tested on your first days of life. So what this randomized control trial created is that figure which tells you about the numbers of PCT that you should be expecting in healthy newborns. So then we went back and said, you know, anything above those numbers, it's either amber category or red category, and you should either repeat the PCT if it is amber or continue antibiotic if it's red. Unfortunately, this didn't work. Theoretically, it sounds amazing, but it didn't work, unfortunately, because we're getting a lot of high PCTs, especially in preterm babies and babies with respiratory distress, because as we said, procalcitonin is an acute phase reactant. So there are other reasons why it's increased, and neonates, the two most common reasons why it's physiologically increased, which is why it is increased, sometimes physiologically and sometimes as a response to some sort of inflammation, was prematurity. So even late preterm babies will have higher numbers of PCTs when CRPs were negative and blood cultures were negative. And then respiratory distress syndrome, which you were getting preterm babies with respiratory distress and a PCT of 70. So that was really, really confusing people. And then we were ending up giving more antibiotics in early onset sepsis than we would like to. And that in comparison to what we were giving as well. And then people, I think they were losing trust on the biomarkers. So they were just ignoring the result for the babies on late onset sepsis as well, that were screened for suspected late onset sepsis. So I think at some point we really I think we really confused the team. And this is where quality improvement comes, and this is where you should be like reassessing continuously your progress and your actions moving forward. And when we realized that everything has gone out of control, we said, okay, let's break down the problem again. What's our problem? Is that we don't stop antibiotics in late onset sepsis when this project started within 24 hours, probably because people are so confused about the importance of the biomarker. And we actually calculated our median baseline. So we were stopping antibiotics at 24 hours in 1 out of 4 babies that were screened for late onset sepsis, and they had negative PCT results. So only 25% of the cases. So we broke down the problem and we decided that we will stop using PCT in early onset sepsis because it was just out of control and we couldn't translate the results. And then we also liaised with the laboratory and highlighted the importance of getting the PCT as quickly as possible because we're also getting delayed results. And then we were working with another QI group which aimed to reduce the hemolyzed samples in order to make sure that we're using the correct bottles, we're getting the correct amount of blood. And then we were asking this. The final bit was that we asked all the senior consultants and reps to make sure that they are making clear comments about when the antibiotics should be stopped, and focusing on the PCT and chasing actually that result. So this is how we defined our baseline data. Again, 12 weeks worth of data, and that's, as you can tell, this is the variability of practice. So that's line chart. What tells you is that there was a massive variability. So there were weeks that nobody was. So on your y-axis, you can see that we are measuring the antibiotics courses for late onset sepsis with negative PCT that we followed the guideline and we stopped antibiotics in 24 hours. So you could see where our median baseline was. It was very low. It was at 25%. And then our x-axis was the amount of weeks that we collected that data for. So there were weeks that the consultant that was on call obviously had confidence on the biomarker. So we were stopping antibiotics at 24 hours with negative PCT results in 100% of cases. And there were weeks that the results were completely ignored. And you will see that there were quite a few weeks in a week period of time. So again, we worked on our PDSA cycle and we did the things that we mentioned before, and we recollected our data. We had more courses of antibiotics when we're recollecting our data. We excluded those that the babies were already on antibiotics and the treatment was escalated, the amber and the red cases. And we also excluded the cases that had clinical concerns and the decision was for longer treatment was made because there was some chest x-ray changes that people felt that they needed more prolonged course of antibiotics. So we excluded the cases that, you know, the clinical concern was there because at the end of the day, we're talking about the biomarkers. So if we have clinical concerns about our patients, we are only using the biomarkers on the clinical context. So we shouldn't be focusing on the numbers. So we excluded these cases again, and we only focus on these courses of antibiotics that had negative PCTs and negative CRPs. So by working on our PDSA cycles, we have managed to improve things. We still have weeks that people just ignore PCT and we just again drop to 0%. But we have been consistently the last, and that's something that was completed very recently. We have just managed to maintain our numbers above the median baseline for the vast majority of weeks. And what we are doing next, so we are now in the process of prospective review of data for 4 to 6 weeks. Is change sustained? This is happening at the same time with the new rotation of doctors, so I don't know whether I should be optimistic for that or not. Yesterday we did a PCT lunch and learn, so we invited a rep that came from Nottingham or no, he came from Leicester. Who is working a lot of PCT. He read about our work that we have done because we have published a couple of, we have presented a couple of posters, and he offered to come and talk about PCT, which happened yesterday. It was very helpful, and as part of that, not teaching session, as part of that meeting with him yesterday, we decided to look into a little bit more on our data, our numbers, and see whether we can actually use point of care PCT because we really struggle still with results coming back within time, with not as much PCT samples because we tackled the problem of the wrong bottles being used in occasions, but it's just about the time that it takes for the PCT to come back. And that's what we are going to focus on now. And for me to finish, oh yeah, 3 o'clock, great. Not that late. This is the local resources available. Leeds is really focusing on quality improvement. There are training sessions, teaching sessions through ESR. There is a QI network that shares information from all the departments of the trust. And we do have a couple of QI leads in Children's Hospital, Kirsty and Liz, who are really great support. But where my training is coming from and what I would recommend people to do is to have a look on the NHS Improvement Academy website. They do have 3 courses, the bronze, the silver and the gold course. Bronze is a webinar that it only lasts, actually an e-learning that only lasts a couple of hours and gives you a certificate and talks about the basics of QI methodology. And then the silver is a little bit more in detail, talks you about how to get ideas around QI. It's a 1-day course, and I would probably recommend that to more senior people, the gold certificate, which is or QI for leaders, which I recently completed in summer, which is about delivering change within a department, within a trust, and how you can sustain the change that you have already achieved, and how to actually spread the change to other departments, to other trusts, or even nationally. For the trainees that are present on this talk, when you are at ST5 level and you will complete your sprint, there are a couple of QI teaching days. I'm faculty for both of them. Which are being organized by a QI company called QIC, which by the end of it, it gives you the opportunity to complete a course which is called Improve One Thing which normally costs £1,000. But what this course helps you to do is to learn how, through small change, make change on the problem that you have spotted on your department or in your life, because they actually have done that as well, and talk to you through PDSA cycles, other forms of QA methodology like fishbone diagrams, and give you the baseline, the basic knowledge that you need to start to embark your QA journey, and that's as part of Sprint. These are the references, and if you feel that you want to my slides, I'm very happy to share them, and I'm happy for any questions. And I'm so sorry if that felt long. Yeah.
Thank you, Rania. That was really useful. I'll throw it open if we got like the next 2 minutes. Sorry, we're running late, people. If in the next 2 minutes, if anyone has any questions they want to ask, that would we have some time for that?
Yeah, I'd love to ask a question. That was an excellent talk. Thank you. PCT,
Yep.
late onset sepsis. Can I just clarify your protocol then for someone starting antibiotics? Do you measure CRP and PCT at initiation of antibiotics, but you only get the PCT results slightly after the CRP result?
Yeah,
Is that right?
That's a problem that we have. Yes, that's right. So
But
late onset sepsis, PCT, we ask for a full blood count, the CRP, and the blood culture, obviously, but we have now added PCT on that. The main problem that we have is that we get CRP results after a couple of hours maximum, and we get PCT results sometimes after 6 hours, especially when you screen a baby late in the evening and the night biochem team comes. Sometimes we get the results the next morning, which is defeats of the biomarker.
and so in that cohort that you had, have you the number of babies that had a low PCT, and did any of those go on to have a positive culture?
No,
Zero.
zero.
That's fascinating.
I
And
think one
that's,
of the things. Sorry.
yeah, just quickly, how many patients is that?
So we have done different types. So the first audit had 50 patients approximately. By patients, we do it by courses of antibiotics, because obviously our babies are extreme preterms that have like multiple courses of antibiotics throughout their length of stay. So it was 50 courses of antibiotics on the first audit bit. Then it was another how many courses? Another 70 courses of antibiotics on the baseline data calculation of the reinitiation of the project, and then another 100 of courses. So total of 200 of courses of antibiotics.
But how many positive cultures?
So the first bit had approximately 5-6 positive cultures, and then how many positive cultures? And I think roughly like 5 to 6 positive cultures in the other two data collection bits. So total.
Very interesting. Thank you.